Okay. Good morning, good afternoon, good evening, everyone. On behalf of BIC and Translumina, it's my pleasure to welcome you all. So we have now arrived at the great session, I think greatest of all. This is a showstopper of our entire program. So we have the most eminent cardiology faculty globally and from national faculty now present with us. So it's my absolute pleasure to introduce you to the faculty present. So we have with us today Dr. Adnan Kastrati. Dr. Kastrati is head of the Department International Cardiology, German Heart Center, Munich. He's also published some of the most credible publications in international cardiology under the name ISR, which has given newer directions to cardiologists world over for delivering the best clinical outcomes. Welcome, Dr. Kastrati. We also have with us Dr. Ajit Mulasari. Dr. Mulasari is Director, Department of Cardiology at Madras Medical Mission. He's one of the eminent personalities in India in the field of intervention cardiology and the only center to have OCT core lab in India. So welcome, Dr. Ajit. Then we also have Professor D.S. Gambhir, another eminent cardiologist from the country, a great professor, a great teacher. I'm sure most of the people who are listening have been trained and studied under him. He's currently chairman and group director for cardiology at Kailash Hospitals. Welcome, Dr. Gambhir, to this show. So we are actually waiting for Dr. Rajneesh Kapoor to join. So he's getting delayed for next 15-20 minutes. So I'm also taking this liberty to introduce all other eminent panelists which are with us. So we have with us Dr. Anil Dhal. Dr. Anil Dhal is HOD Cardiology from Janakpuri Super Specialty Hospital. Welcome, Dr. Dhal. We have Dr. Arun Kalyan Sundaram with us. Welcome, Dr. Sundaram. He's HOD, he's Consultant Intervention Cardiology at Promed Hospital, Chennai. Great CTO expert. Welcome, Dr. Kalyan Sundaram. We also have with us Dr. Jayesh Prajapati. He's Professor and HOD at UN Mehta Heart Institute. Welcome, sir. We have with us Dr. Mahesh Basarge. He's Director and Intervention Cardiologist at Baroda Heart Institute. Welcome to the show, sir. Then we have Dr. Prabhakar Shetty. He's Head of the Department Intervention Cardiology at Columbia Asia Hospital. He is also with us today. Then we have Dr. Purshottam Lal. His detailed introduction will be given by Dr. Kastrati because he's the first presenter with us, but he's Chairman Cardiology at Metro Group of Hospitals. Then obviously we have Dr. Kastrati who will also be presenting, which I've already introduced. Then we also have Professor Carlo Di Mario, another international faculty with us. He's Head Department of Intervention Cardiology from Florence, Italy. I also have pleasure of introducing Dr. Seth Bilazarian. He is Vice President Medical and Intervention Cardiologist now with Abiomed. Welcome, Dr. Seth. Then we have Dr. Sai Satish. He's a Senior Intervention Cardiologist from Apollo Hospital, Chennai. After Dr. Sai Satish, we have Professor Hussein. He's from Cairo University, UAE. Welcome, Professor Hussein. Then from the peripheral intervention side, we have Dr. Lorenzo. He's from London, Northwest Healthcare NHS Trust. Welcome, Dr. Lorenzo. And last but not the least, we have Dr. Ravindra Rao. He is Chairman of Rajasthan Hospital, Jaipur. So in all, great eminent faculty with us. We could not ask for a better, sort of faculty with this great session. So over to you, Dr. Kastrati. I will like you to introduce Dr. Lal and, take this session forward. And by the time I think we'll have Dr. Kapoor with us. Over to you, Dr. Kastrati.
Yeah, thank you very much. Thank you for having me here. It is also fortunate to have Dr. Lal here with us. I don't see you, Dr. Lal, in meetings very often, and that's why I thank you very much for accepting to be with us this afternoon. I have traveled a lot to India and noticed the respect and admiration that a lot of young cardiologists have for Dr. Lal. Many international faculty members that are present here in this meeting may not know much about him. Based on his achievements, he can be considered a father of interventional cardiology in India. He came back to India after an excellent career in the US and has since become an icon for affordable cardiac treatments for poor people in India. He is awarded the high civilian honor Padma Vibhushan in India. Dr. Lal has the unique distinction of pioneering the largest number of procedures in the field of structural and coronary interventions in India. He did the first septal defect closure and balloon mitral valvuloplasty, the first coronary stent implantation and rotablation in India. I was also amazed to know that he implanted the first core valve in the world way back in 2004 in his hospital. Despite so many achievements, he remains a humble and quiet individual. And it is a pleasure for me and for all to listen now to him. Dr. Lal.
Thank you so much, Professor Kastrati. Really great. And I thank all the eminent cardiologists, Dr. Gambhir, Dr. Dhal, Dr. Ajit, and all the cardiologists, and particularly thankful to the organizers to convince me to give this lecture. And well, this is one, where we keep on saying first time, and I feel always a bit embarrassed, but bear with me if it is written a little too often, because my secretary put all the things together. And I'll just go fast because I got 15 minutes to go, and I'll start. Well, I'll go back 90 years back. My regards to Dr. Forsman, who did self-catheterization 75 years back. Big people did a lot of hard work, how to develop the catheter, and our thanks to Dr. Churkin, Dr. Sones, and Dr. Knudzik. Dr. Knudzik is the one who made the life for the cardiologist by introducing all these interventional cardiologists, and is the first balloon. And when I talk about bit evolution of interventional cardiology in India, Dr. Manchanda, he happened to do the first coronary angioplasty on the right coronary artery in '84. And then we had a lot of issues with the, one occlusion, lesion, and restenosis. So first, way back in '88, I had the opportunity to work with Professor Kaltenbach, and this was a very unique device. I was very excited, met Fulbragg, and that's where I worked with Dr. Zevert quite a bit. He was also getting that training at the same time. Was good to us, was not causing any perforation, but then again, the cost effectiveness and the success rate was of consideration. Okay. This was the one, we did about maybe 22 cases, but then due to the cost involved, we could not do very many cases. And then came coronary atherectomy directional, and again, as you know, that it is very exciting situation. And this cutter, going up and down and taking the fat out, we all was excited that it will reduce the restenosis, but really it did not. And so these are, few of the first papers in the CSI, whether slow rotational or coronary atherectomy, extraction coronary atherectomy, etc. And rotablator was again advice. Again, we thought that calcified blocks were major limitation even today, And in 92, I used to work in America with Dr. Buchbiner, and told me that I should proctor. But then, I was more interested in India, and I'm grateful to all Reef who helped me to bring the road operator in the country. And, this is the all operators. But again, one hope was there that it will reduce. And this is just one sample. It made our life so easy, as you can see. Such a heavily calcified artery, which we do all the time, it's saving a lot of the patient from the bypass, and it's a LED. And then, after opening, and if I go further, it was before and after, and road ablation, again, this is our presentation in the Cardiac Society of India. Coronary stenting, we started in July 91, and this was my patient from Maldives, right coronary block. It had acute occlusion. That was the time we used to use for the bailout situations, and Mr. Smile happened to be my patient that time. He was 52-year-old. He still comes to me all the way from Maldives to Noida, Delhi, and he's the father-in-law of the president of Maldives, very happy. And this the multiple presentations, but this was the first paper of the country on the coronary stenting, the tantalum coronary stenting, which I presented in 91. And then, there was some mention of gold stent, various things we used to think to reduce the amount of blood clot. Now, I remember in 92, when I was giving the lecture on coronary stenting in the annual meeting of the Cardiac Society of India, it was like that if the stenting is worse than the disease. But after decade, it became the revolutionary treatment, and you can see how much the reduction of the situation, and it was so good stuff, drug eluting, and you just feel that you just put it and anywhere you want, and the trick, and beautiful results. And then we start putting stents, in the carotid artery, in the artery, and in the aorta, you see how much acute band, and then after the stent. So this was a very good case for us. A doctor came from Chandigarh, in 98, in the Boston Scientific. They helped me to do this case, the aneurysm with the AAA involving the iliac arteries. And this was the, our presentation in the CSI. Moving to the mitral valvuloplasty, we used to do double valve, double balloon, and was a bit cumbersome. Was very, again, happy to know about the Inu balloon, while I was doing my training in interventional cardiology in Germany. And that time, I met Dr. Inu, and then I went to Tokyo and spent some time with him. And then, we did balloon till today, made the balloon of choice. And if you can see, that time it was $3,000, this balloon. But Dr. Inu personally was very grateful to reduce it 1,000 for India. Initially, they were worried even to send the balloon to India, but finally I convinced him, and now it's a very good. This is, our first comparison with the other techniques of balloon. And then, as you know, the balloon is so good that we started in pregnancy doing only with echo. There was no need of cath lab, particularly when there was a big septum. Now the things are different. I'm talking about so maybe 20, 25 years back. And there is the person who led me to do this, and he came to me while I was a fellow with 5,000 rupees in his pocket. At that time, it was costing 70, and I was the only one doing this case. So I took him to home, and they kept overnight. At 4 o'clock in the morning, I brought to the echo lab and did this case. The credit goes to the one who did the echo for me as well as the balloon, and thereafter I standardized the technique for the pregnancy. And again, this balloon we were using for the aortic as well as the pulmonary valve, and very, very good balloon. Aortic valvuloplasty, as we all know, balloon has not much place, but in certain situations, there was a time in 91, 92, when there was cardiogenic shock, the surgeons were even worried to touch such kind of case. And this is one example where left atrial femoral bypass port, taking the blood from the left atrium and giving to the aorta. The roller pump, now I collected, dilator, wire and atherectomy catheter. And, this is the case 58-year-old in cardiogenic shock, where the surgeons refused. But what is the beauty of this left atrial femoral bypass port was that we can inflate the balloon for a long time, and initially I thought that it would reduce the restenosis. Honestly speaking, I did not have that number of cases where I can draw the conclusion, but certainly where the surgery was not possible at the time, and we used to do that case, and then later on it came to tandem heart device and a very expensive device, and this was the, first paper, my first paper in India. As a matter of fact, first when I entered, it was first early in the morning, gave the paper. Then we moved to sported angioplasty. Again, it was expensive for India because of the oxygenator. And with left atrial femoral bypass port, we did not have to, put the time. Now, these are sported angioplasty, as you see, with the cardiopulmonary bypass port. And then the same device now we are doing ECMO, And this I developed the catheter, Schneider catheter, putting in the left ventricle, taking the blood out with the roller pump, thanks to roller pump, and into the aorta. And the same thing, it turned out to be Impella device. It was more a poor muscle situation. Now with the PDA, that was the time in the PDA we used to do in India in the other center, what we call rash kind technique, very beautifully looking device. This is the PDA, aorta and pulmonary artery, and this the, but only thing was very expensive, and I always wanted that something we can do cheap, and then we did with the force, with the modified technique, Portsman technique, and this is the plug we used to put, and was very good, 12-year-old, very cheap and effective method. And this is very interesting. The Russian technique was the one where, with the rash kind, we need some learning curve. There was not much learning curve. And then we started doing very cheap, it's a low cost procedure. And we compared with a lot of wrong non-rash kind techniques with the other techniques, to see that. Now after the implants came, the PDA became so simple. Moving to ASD was very much desire, how we can do it. And one lady, while I used to visit Apollo, she will come, bring his son, and that I want to get done his whole closer from you only. I did not know Tamil, but then she will use some translator. And she really encouraged me to do the case. And this was the monodisc Y with the Bosniak to develop, and then we developed together. And this was the animal studies. And this was, we did about 33 cases, but again, the Amplas device came, and there are other devices were nothing in front, This I want to show, I had a special interest in the VSD closure, and again, thanks to Dr. Amplas, who developed this device, very simple to put it. Now, this is one patient which I want to share with you, 15-year-old endocrinology where the surgery was not possible, some overriding physiology of tetralogy, and that was very big challenge where we did the pulmonary valve dilatation and VSD closure with some override, and patient till today, he is doing fine. Now, these are some of the publications about the ASD and our first paper at CSI, and there's some. Now, I'm moving to the core valve, you all know, but I will go back in 92 when I was given the oration by the Cardiological Society of India. And I said that one day we will definitely do AVR. No, I'm talking about 92, and that time I showed this animal experiments, so this was just someday we will do it, and with this valve, which last only few hours on the studies done at the Anderson Hospital, and so the first was 2002, and then Dr. Alan Crevier, great person who did it, and then Dr. Sikun, he came to our institute. We discussed about it, about the core valve. He detailed everything, and we went over various studies. There was some mutual understanding, how to go further. And then that dream which I had 92, finally Dr. Sikun made it, and we did right here where I'm sitting on July 12th, the first case. I now, with the shortage of time, will not go into much of the detail, but it was a very suitable case, suffering from the cancer, but the chemotherapy was must, and that was the time with the aortic stenosis. We did that case. The patient had a baseline renal problem, but it was a time, we did general anesthesia. I remember how Dr. Sikun was running in the cath lab, doing it. Everybody was nervous, but God was kind, and this procedure went very well, and whatever the success thing, entry to the arteries, bringing device to the aortic valve, and satisfactory implantation. And this I will show with the first case on 12th July. And if you can see that, if it will not come, then I'll move to the further. Some AR. And iliac arteries, again, we have to go up to the common carotid artery. In this case, a heart lung machine we kept right inside our cath. First, we did the balloon angioplasty and pacing wire TE and bringing the very heavy, and finally, everything was fine. There was no hardly any AR, if you can see, and the patient did very well from aortic point of view. And these are the few slides, Dr. Grube, Dr. Labordi, Dr. Sikun, and this was the certificate Dr. Sikun gave me, because I being the primary operator, he was very happy the way we handled this case. And this is the post-CCU. Again, I will not go into the detail. Patient did very well for 5 days, from valve point of view. However, due to baseline renal problem, the renal and the terminal case of cancer, we had certain, and then we lost him on the 6th day. This was the publication in Indian Heart Journal, and this was the journey from 21 French to 14 French, and thereafter, we remember, and a lot of countries are calling me to present the first case where I had much more details to present, and then we moved to the pre-crimped thing after 12 years, in the where the LED was closed and pre-crimped, and just to show Dr. Sievert, we were trained together, very good friend, And this is a patient we did with the pre-crimp, along with the opening of the LED artery. And these are my humble contributions in the interventional cardiology, and then for the development of interventional cardiology, I was given prestigious BC Roy Award by the president of the country. And this is the center where I work, Metro Heart Institute, Noida. We have small center, low middle class people we treat. We never return any patient for want of money, but expensive procedures like mitral clip are very difficult for us to think to it. But maybe with paucity of time, all these things we will be. Thank you so
much. Thank you, Dr. Lal. So we also have now our moderator, Dr. Rajneesh Kapoor. I think he has joined us. Welcome, Dr. Kapoor.
Yeah, thanks, Paritosh. Thanks.
I think, sir, you please take over. So since you were not there, I was.
Yeah, thank you. Thank you. I'll take care.
Yeah.
Thanks, Dr. Lal.
In the interest of time, we can go to the next session and then take questions. You take over. So yeah.
Yeah, sure. So thank you, Dr. Purshottam. It was a really nice talk. Sorry, I was a bit late, but I would request you to be on meetings and giving orations. On further meetings we require your orations, and these are really wonderful and valuable. So please accept my request for further meetings also.
much.
Wonderful to have you.
Thank you.
Yeah, so I'll move further, and Dr. Kastrati, we all know, is a highly respected name, not only in Germany, in India also. We have been really privileged to have him at many of our forums and webinars and conferences, and we have always listened to him with great vigor. So his orations have been wonderful, actually. So I'll invite Dr. Kastrati to deliver a talk on drug-eluting stents, new era and new concerns. Is polymer free the future of DES technology? And just to add about him, he has been a part of many trials which are ongoing also, and in the past also. So this is all his work, actually, polymer free DES and how it's going to impact the PCIs. So over to you, Dr. Kastrati. It's wonderful to have you, sir.
Thank you, Dr. Kapoor. In fact, the concerns about the polymers with drug-eluting stents are not very new. They are almost as old as the drug-eluting stents themselves. So I have put here a study from the group of Virmani, and they ended with this conclusion here that the perfect polymer remains unknown, and all polymers in use today induce some degree of inflammation. Interestingly enough, this degree of inflammation was in proportion to the polymer mass on the stent. And the best illustration of this relation between the degree of inflammation and the mass of polymer is shown by the resorbable scaffold, which has a strut thickness of 150 micron. All is polymer. And I have put here only one study, one meta-analysis done from my colleague, Salvatore Cassese, who collected all the randomized trials comparing the absorbed stent with the science stent. And you see here the main results of this pooled analysis, about 7,000 patients, followed up for up to 24 months. And you see that both the incidence of the primary endpoint, target lesion failure, was increased by 32% with the use of the absorbed stent, and the risk of stent thrombosis was threefold that of the science stent. What criteria should meet a polymer-free drug-eluting stents to be acceptable? It should be efficacious, and it should be safe by improving the healing of the arterial healing. This is a study done in Hamburg, not in Munich, not in our center. It's to the north of Germany, and published 2008. They used the ESA stent platform with the unique microporous surface. And they coated it with sirolimus and compared the data in the rat model with the bare metal stent. And you see two cases here, one with bare metal stents with a lot of neointima, one with sirolimus eluting stent, polymer-free, with a microporous surface, no neointima at all. At the end, there was a significant reduction in the luminal obliteration with the sirolimus eluting stent without polymer as compared to the bare metal stent. What's about the safety? How can we evaluate the safety of the stents? And here I'm showing you the healing score was proposed by Lorenzo Patrone in the group of Windecker in 2016. And you see the components of this score. Intraluminal mass has 4 points, if you see here in the OCT, malopposed and uncovered stent 3 points, uncovered but opposed struts 2 points, malopposed covered stent 1 point, and excessive neointima 1 point. And you have to imagine that the lower healing score is showing a better healing for the stent. Here is a study done with polymer-free sirolimus eluting stent. It is a serial OCT study having the examination done at 3 and 6 months after stent implantation. And you see the healing score after 3 months is not that good, 171, but it went down to 5, to a very low score at 6 months. Vivo ISAR is a unique, not a simple polymer-free drug-eluting stent. So it's important in drug-eluting stent technology to have adequate release kinetics of the drug. And you see here in the red, the release kinetics achieved by the cipher stent. Even with the microporous surface, you have a fast release kinetics, so that may not be so effective as the release kinetics achieved by the polymer-based drug-eluting stents. So the idea here was how to go down with the release kinetics achieved by polymer-free drug-eluting stents. And we tried different substances and came to the Probocol due to 2 reasons. One, Probocol is almost the only substance that has been orally effective against restenosis. And here is a publication in New England Journal of Medicine, 1997. But the other reason for using or for choosing Probocol in the dual drug-eluting stent technology is that the Probocol is highly lipophilic, able to slow down the release kinetics of the Libos drug. So, and we go on, we went on with the preclinical studies. We assessed the release kinetics achieved by the dual drug-eluting stent and compared with the sirolimus eluting stent with biodegradable polymer. And you see here the release kinetics up to 30 days. The yellow is the curve achieved by the sirolimus biodegradable polymer-based drug-eluting stent, and the 2 other curves in blue and also in black are the curves for sirolimus and for Probocol. And you see that using this combination, you can achieve a slow release kinetics comparable to that achieved by polymer-based drug-eluting stents. Here also some animal data achieved with this dual drug-eluting stents. And if you compare the data with bare metal stent and with also with biodegradable polymer-based sirolimus eluting stent, you see less fibrin deposition and much less also inflammation. And the endothelialization rate is comparable to that achieved by bare metal stents. The largest studies done with the dual drug-eluting stent with the Viva ISAR stent is the ISAR Test 5 trial. 3,002 patients with de novo lesions, and one group had 2,002 patients, and was in this group was used the Vivo ISAR test, and the other control group was the resolute sirolimus eluting stents in 1,000 patients. So these are the first 10-year data published 1 year ago in JET. And you see that if you compare these two stent technologies, there is no difference in with respect to the primary endpoint, the device-oriented composite endpoint with sirolimus plus prabocorticotic stent as compared to sirolimus eluting stent. And most importantly, both the stents have been associated with a very, very low incidence of probable and definite stent thrombosis, less than 2% in 2 years without any difference between them. Very interesting results came out when we looked at the outcomes according to the diabetes status. And you see here, it is the patient-oriented outcome. That means all-cause death, all revascularizations and myocardial infarction in the patients. Why there was no difference in non-diabetics up to 10 years between the Endeavor Resolute stent and the Vivo Isar stent, there was almost a significant difference in diabetics with a lower incidence achieved with the Vivo Isar stent in this subset of patients. Let's look now at the stent thrombosis rates from randomized controlled trials with 10-year follow-up. Here we have the definite stent thrombosis rate from the CTAX trial, which was one of the first trials comparing Cypher and Taxus in patients with coronary artery disease. And you see that the composite here for both, for Taxus and sirolimus, was about 6%. In the SORT-OUT 2 trial, there was also a comparison between Cypher and Taxus, and you see the combination of definite and probable stent thrombosis, very high rates for both stents between 8 and 10%. And here are the rates of definite and probable stent thrombosis for the Vivo Isar stent in the Isar test 5 trial. It is less than 2%. But even if we take a second generation diabetes stent, because Cypher and Taxus were both first generation, you see that the definite and probable stent thrombosis rate in the Viva Isar compares very well with what shown for the Xi stent in the Isar test for up to 10 years. If we take a very recent trial, the Onyx trial, definite and probable stent thrombosis achieved through the biofreedom, which was also a polymer-free diabetes stent, but without a second drug, as it is the case with the Viva Isar trial. You see that it is 2% up to 1 year, but we don't have later on data. So where we are now with polymer-free diabetes stent, although the available data do not show that polymer-free diabetes stents are superior to polymer-based diabetes stents of second generation, their equivalence shows at least that polymers are not needed to achieve good results. Have we solved the problem of in-stent restenosis? Here is the 10-year US registry of PCIs, and 10% of the PCI done within the 10-year period, it is 10% of the 5 million, this is the largest PCI registry worldwide, are done for in-stent restenosis. And if you see here the curves, about 6% are related to diabetes stent technology and 4% to bare metal stents. Most importantly, the in-stent restenosis is not a benign pathology, but it is associated with unstable angina in 50% of the cases, and also with non-stable and stable if it occurs. Have we come to the end of the road with diabetes stents? We, together with my colleague, Dr. Kufner, we wrote an editorial saying at the end that more effective and durable prevention of restenosis will remain a target of locally applied treatments even in the years to come. This will still require further improvement in test technologies, including adequately tailored drug release kinetics, development of new anti-proliferative drugs, and metal or bioresorbable stent scaffold backbones. And here the example showing that we are still working in this field, and we have identified a new target for the fight against restenosis, PRPC6. And there are several lines of evidence published in European Heart Journal this year showing its importance. Here, the knockout mouse model showing that in the knockout mouse, there was less neointima area as compared to the wild type. This is a clinical study showing that the genotype of TRPC6 associated with the higher plasma levels is also associated with higher incidence of restenosis as compared to the other genotypes. The third line of evidence is showing that the antagonism of this TRPC6 is also associated with lower migration and lower proliferation. With this substance, SAR 7334, we are working with Transluminal to have a new generation of trilumic stents. Thank you very much for your attention.
Yeah, thanks, Dr. Kastrati. As always, highlighting this trial in a really good way. Dr. Ajit, would you like to add some points? And Dr. Gambhir is also here. We're privileged to have really good chairpersons with us. So Dr. Gambhir and Dr. Ajit, can I request you to just add something to this?
Thank you, Rajneesh, and thank you, Dr. Kastrati, for, as usual, a brilliant presentation. I think the most important thing we are seeing now is that we've reached a 10-year point of time where the restenosis rates for most stents is about 10%, but we're now seeing safety of some of these polymer-free stents, especially the technology what you're talking about in terms of reducing not only restenosis, but safety in terms of stent thrombosis. And I think this will make two things very clear, that these stents are safe and we can reduce the antiplatelet regimens faster and faster in most patients so that you don't have the risk of bleeding. So I think this sort of technologies have reached a sort of point of time where now proving something is better than these technologies is going to be difficult, but we'll need a lot of work to prove in randomized trials that a new stent is going to be better than what we already have. Thank you. Thank you, Dr. Kastrati.
Yeah, one sentence from Dr. Gambhir.
Thank you, Rajneesh, and thank you, Dr. Kastrati. The only thing that I have to add is that there is certainly a scope for improvement in our stent designs and in the polymers. And I think it's very heartening to note that these polymer-free stents, although have no difference in the restenosis rate, but are possibly more, free of stent thrombosis. And that is what we want. We want to see in the near future that if we can cut down the antiplatelet agents to 1 month or even lesser than that, well, we have achieved the job. Because there are a lot of patients who come with fractures and so many other problems which may prevent us from giving them antiplatelet drugs for 3 months, 6 months, although we have now trials with 1 month. But these stents certainly are a hope for the future. And I must compliment Adnan for doing a great job in this field. Thank you very much, I think.
Thank you very much. Thank you.
Thank you. Thank you. And Dr. Adnan, you're looking wonderful. Smart. Okay. So we move on to the next one. I think Dr. DiMario, I can see him, he's with us, but can I just have a liberty of changing the sequence a little bit? I just got a request that Dr. Sai Satish has to do some talk somewhere else also. So can we engage Dr. Sai prior to Dr. DiMario? Okay, I'll take the call. So Dr. Sai's presentation is on robotic PCI. Is it reality? And a special case of mitra clip. I'm really privileged to have Sai as a very good friend, and he's pretty active and doing all the challenging cases and spreading the awareness of all the structural heart interventions. It's really good to have Sai with us. So Sai, please go on with your presentation.
Thank you so much, Rajneesh. It's so nice to see you. Of course, lovely lecture from Dr. Kastrati. Dr. DiMario, I owe you one. Thank you so much for allowing me to do this. At 7:20, I have another talk. It's so kind of you to oblige. Dr. Ajit, Professor Gambhir, it's such a pleasure to be here in front of all of you. The only thing I'd like more is to actually be face-to-face in front of all of you.
Great.
2 years of Zoom meetings is a bit much.
I think you're doing a great job.
without much, hi Arun, without much ado, I'm going to be quite good. I'm going to start my timer so I don't exceed and do any truancy, okay? So very quickly, I'm going to share my screen. Since I am partial towards structural, yes, there I went and said it on an open forum. I'm going to start off with the mitral talk, and then I'll move on. My initial, I know I was supposed to have a quick case-based discussion, but because India is still fairly new in its MitraClip journey, I'm going to just give 2 or 3 introductory slides. I request the experienced operators to bear with me. So the reality, 26 million cases of heart failure are diagnosed worldwide. It's estimated it's about 37.7 million if you take the undiagnosed cases. What is the fact? 1 in 5 of us have a lifetime risk of developing heart failure. Another fact, the #1 cause of global hospitalization is heart failure. And over 50% of these patients are readmitted within 6 months of discharge. So heart failure is a significant burden. There are several reasons for heart failure, but mitral regurgitation is a significant component worsening outcomes in these heart failure patients. We can broadly divide mitral regurgitation into 2 types. One is the degenerative mitral regurgitation, where there is defects of the leaflets, the subvalvular apparatus, and the chordae, predominantly the flails. And the second is the secondary mitral regurgitation, the cardiomyopathies, the ischemic, the dilated LV, and the moving apart of the leaflets, and thereby the mitral regurgitation. The MitraClip is currently the only percutaneous technology effective in both functional and degenerative MR. As we all know, mitral regurgitation begets more mitral regurgitation. It's a self-propagating disease. This is an interesting slide which says that mitral valve disease is estimated to be at least 2 to 3 times that of aortic valve disease. Even in a country like America, data shows that a very small percentage of these patients are treated. 4 million patients are diagnosed approximately every year, and only 1.5 are treated. So in India, with a population close to 1.3 billion, we should have at least this many cases. What is the MitraClip? The MitraClip facilitates the reconstruction of an insufficient mitral valve through tissue approximation. It's a recapitulation of and refinement of the Alfieri stitch. It's a mechanical solution to a mechanical problem. Repair creates a tissue bridge. I'm not going to go into data. I think it's too late in the evening for that. So these are the landmark studies that were there that established MitraClip and positioned it where it is positioned today. These are few noteworthy points. The QAPT says in secondary MR, MitraClip is safe in heart failure. There is a durable reduction in MR. There's a reduced rate of heart failure-related hospitalizations. There is improved survival, quality of life sustained up to 24 months. It's the first therapy shown to improve the life of patients. EXPAND was presented recently in TCT 2020. The results were seen across both, not just the DMR group, which was COAPT, but also against, not just the FMR group, which was COAPT, but also across the DMR group. And they were pretty similar. They were sustainable with significant reduction in MR, sustained reduction in MR, and improvement of quality of life. Now that that's done, let's move on to the cases. So this pandemic only brings the worst of the worst out to hospital. And in this absolutely incapacitating second wave, we've seen some really sick patients come in because they keep staying at home till they get too sick. I'd like to present 2 or 3 cases that I had to do in the last 3 weeks. All of them came in cardiogenic shock. The first case, I have a screenshot from the Sun who said that the patient got extremely sick. He's an 86-year-old gentleman, diabetic and hypertensive, coronary artery disease. He had an acute MI with an ad hoc primary PCI from the left main into the LCX. He had severe MR, flail P2, a little more towards the P3, presented with cardiogenic shock, very low output state, lactate 5.6, liver enzymes rising, creatinine 1.9, unable to come off the balloon pump, unable to come off the ventilator. He was shifted by ambulance for a MitraClip as a last ditch attempt. So when you look at this, you can see the nice little gap of the overriding of the P2, overriding of the PML over the AML, and a huge regurgitant jet through that overriding. It was a nice wide jet. The mitral valve area was good enough. So the problem we have with these acute MRs is that the LA doesn't have time to enlarge. So what happens? I have a really tiny LA, and if I were to try and reach the mitral valve through the fossa, I would have no height to be able to clip the valve at all. So you can see how high this puncture is. I had to improvise a really high. It was just below the SVC-RA junction. You can look at the entry site on this 3D image. So did the puncture. And as the clip entered the LA, even before I could straddle, the clip is already in the superior pulmonary vein. So now I had no choice, but I can't bend it down without pulling it back because of the Comedian ridge or the Warfarin ridge. So what I had to do, I actually had to pull the entire guide system back into the RA to be free of the Comedian ridge, then turn the clip towards the valve. You can see, if you look at this fluoro, you will look at the clip in the superior pulmonary vein and just drop down into the LA. So once that was done, 3D end phase to check perpendicularity. The only disadvantage of the guide in the RA is that you lose one important motion, which is anterior posterior, but we still managed. Patient was sick, 8 days on balloon pump, 86-year-old, kidney shutting down, lactate going up, systolics barely 80. So the image on the left shows pre-grippers down, then grippers down. And you can see that once I was sure that I had enough tissue in the clip, quickly closed it before it moved anywhere. And you can see almost a dramatic reduction in the MR. The patient was on balloon pump. As you can see the balloon there. The guide is in the RA. The clip was released. And there was almost no MR post-procedure. The gradient post-implant was only 2 millimeters. His LA dropped from 40, mean drop from 21 to 10. This is the patient 24 hours post-procedure. That is him exactly a week later. So this therapy works. It's excellent. It's life-changing. Quickly moving on to the next case. How am I doing? Am I going too fast, Dr. Ajit? Am I okay?
You're fine. Very good. Yes,
Okay.
No problem.
So I'm at 6 minutes, so I have a good another 6 minutes more for this mitral before I switch to the robotic. So moving on to the next case. So this was another patient who came in about a week ago again, a 72-year-old male, diabetic and hypothyroid, CAD, old antral MI, PCI in 2005, severe biventricular dysfunction, ejection fraction 25, severe MR, functional MR. So the first case I showed you was cardiogenic shock with DMR. The second case is a functional MR, worsening on max medication, azotemia, liver derangement, enzymes in the thousands, lactate at 9.6. So the son writes a message saying he is sick, he's acidotic, we are not able to hold pressures. They shifted him all the way from Patna by air ambulance. He missed his first ambulance, but by the time he reached me, he was really sick. Discussed with the family. You can look how abysmal the LV is. My anesthetist was not very happy about taking this case. The minute we gave GA, his systolic pressures dropped to 60 because we knock off all the SVR, and this is what we are left with. Now I had no choice. It was a do or die situation. Torrential dilated LV, torrential MR, huge gap. So you can see the LV hardly moving. So of course, under TEE, puncture, 2 wires. I always keep a pigtail in the LA because it gives me a very good indication. So one of the big concerns in this case with my team was that the LV is so bad, 25 EF in severe MR is even a lower EF. And when we reduce this MR, is the LV going to be able to deal with the afterload? Is the patient going to make it? So one of the strategies was to go in quick, put one big clip because there was a huge gap, put one big XTR, reduce 75% of the MR, and get out, allow the LV to accommodate. I don't even know if there's any rationale in this thinking, but then bring him back 6 months later and finish the job if necessary. So this was the plan. As you can see, this was on 10th May. Went in, the clip was in, checked NFAS, checked the orientation, went bang in the center of the gap, got it, closed it. And when I closed the clip, the first thing my anesthetist said is, what have you done? Because Instantly on the monitor, the pressure went from 70 systolic. He's giving multiple pressors to keep the pressure up. Pressure went up to 110. The LA mean dropped drastically. The CVP went from 24 to 16. So we decided to leave the first clip, and the patient was behaving so well hemodynamically, we decided to go in and do the second one. And this is a really nice maneuver I quite like to do, where I leave the first clip, get the second clip nice and parallel to the first clip, and just go lung down. The minute you go lung down, it goes nice and snug to the first clip, very little maneuvering, very little movement there. And you can see the second clip nice and tight. This is the first clip in place, the second clip nice in that jet. Look at that hole. Huge, big hole, 2 clips in place, double orifice. We went from severe MR to trivial MR. These are the LA pressures, 84. Pre-procedure LA was 84. Post first clip, it was 55. Post second clip, 21. Look at these lactates. 9.5 pre-procedure, 1.36 post-procedure. This was the monitor. His pressures blossomed. They came off all inotropes. CVP dropped to 6. Systolic was 130. Saturation was 100. Heart rate was 69. He literally blossomed. You can see the creatinines within the next 36 hours, the creatinine returned to normal. His liver function returned to normal. This is him 12 hours. This is him 36 hours later at home. Another quick case, and then I'm done with this. We can take, I'm happy to take questions. 80-year-old male, hypotension, azotemia, creatinine 2.5, anterior MI, severe LV dysfunction, severe MR, post-cardiac arrest survivor, multiple hospitalizations, refractory heart failure. Went in, put 1 clip in. Look at that gap. Again, a huge gap, very wide MR jet. We went from that, look at the deep transgastric view. You can see the huge gap, non-coaptation of the mitral valve leaflets. These are kind of cases that we were not sure we could actually approximate these leaflets. Just 1 clip, he went from severe MR to trivial MR, and the gradient was acceptable. 86 LA peak, V wave, 86 to 31. This is a lovely set of messages that it's very important to understand what kind of a difference it makes to the patient. The son says that every morning I'm used to my father sitting up and not lying back and having coffee with him. And I say that's a good thing to miss. And then every month over the last 3 years, he sends me a message saying, thank you, sir, for this miracle. So the first 2 cases were just a couple of weeks ago. This was a refractory heart failure 3 years ago. He's blossomed. His azotemia has come down. He's more alert. He's more active. This is a picture of the patient. Thank you all so much for the patient listening. And I'm on time, 12 minutes, first lecture. Rajneesh, over to you. What would you like me to do next? Shall we take questions, or do you want me to go to the
I think let's involve our panelists. There is a very elite set of panelists also with us. So I think I can call initially 2 of these. Dr. Prajapati, are you there? Dr. Prajapati, any comments, or you want to ask Sai anything?
Yeah. Good evening, and thanks TransLumina for inviting me in this CME. And I want to ask just one thing: whether the mitra clip in acute situation is helpful in case with rupture chordae or flail leaflet in such situation?
It is, Dr. Prajapati. Actually, the first patient I showed you was a ruptured cord with a P2 prolapse post his circ occlusion and infralateral MI. And cardiogenic shock after MI is a messy situation. You never know which way it's going to go. But these were cases where I had only this option because surgical risk is abysmal in these patients. 86 years old, multiple comorbidities, low cardiac output, lactate off the scale. I think I was very blessed to get away with all 3 cases the way I did. But yes, the first patient was a flail. The other 2 were, of course, DMRs. But I have at least 4 cases in my series where I've had papillary muscle ruptures and caudal ruptures post-MI, which I've gone and clipped, and they've done quite well, and they're still doing well to date.
So this is a great job you're doing, and probably this will be the future. Yeah.
I can see Dr. Prabhakar Shetty also here. Dr. Prabhakar, would you like to add a comment here?
Dr. Sai Satish, I have a question. That your results look wonderful, but does every patient you did did like this, or any patients had problems or any issues?
You know, I trained so long with Dr. Matthew, and he has told me one thing. He said, if somebody says they don't have complications, either they've not done enough or they're lying. So I've had two problems, even in my journey. One was a solitary leaflet detachment. See, these myxomatous valves are so diseased that even when you think you have enough hold, sometimes you let the clip go, the heart is rocking and rolling. By the time you get another clip in, it just rips off the first leaflet. And I would have loved to show you that, but I think we're short of time. So what I actually did is I went back in, went right close to that, grabbed that detached clip and put a nice big clip and kept it stable. Beta blocked the patient, got the heart rate down, got the pressure to 160, and hoped and prayed for 6 weeks the second clip held. And she has done well. Sorry.
So my question is not about the complications, but I'm telling you, do all the patients respond so well? That's the question.
So the data, so I have been very fortunate that all the patients that we have done so far are doing well. The oldest one just celebrated her 89th birthday, and she's 3 years having the clip. But what the data also shows is that the key determining factor is MR reduction. As long as you have a good MR reduction, the results are sustainable over a period of time, and the patients do quite well. So I think the American data shows that there's a 4% all-cause mortality in these sick patients by the end of 1 year. But luckily so far, maybe because India is still very early in its journey, all 20 of my cases are very precious babies. I follow up with them periodically on a monthly basis. All of them are doing well. All of them came with class 4 heart failure, went home with barely any symptoms. All of them went from 4+ MR to trivial to trace MR, and all of them have had 0 heart failure related hospitalization till today.
Yeah. So I think for the sake of time, we have to move further, but just one comment, Sai, before I go to the next talk. 2 years back, once we were meeting, you were romancing with the aortic valve. You are changing your romance very quickly. The mitral valve.
The mitral valve is an enticing animal, Rajneesh.
Okay.
It makes you want to cheat and stray.
We are so proud of you. Just keep doing all the innovative stuff. Thank you.
Thank you.
So yeah. So
shall I go to the robotic talk quickly?
Okay. Yeah.
Do we have time for that, or shall I skip? Up to you.
I think if we skip, it's better. We're short of time already.
No problem at all.
Is it okay with you?
I'm at your disposal. The chair's got the thing. It was a pleasure for me to be here.
You have already given us enough, so we'll digesting it.
You also accused me of cheating on my long lost love, so I think I'll take that and walk away.
Don't change your love so fast.
Okay. Thank you so much, Dr. Mario. Again, thank you for the opportunity to do this before you. It was lovely seeing all of you, and I hope to meet you all in person soon. Thank you all.
Yeah.
Bye.
So thanks, Sai. Thanks. It was lovely having you. I move on to the next one. Again, we have a very elite doctor from Italy, Dr. Professor Di Mario. So Professor Di Mario belongs to a beautiful city of Florence from Italy. And he's a professor cardiology at a Careggi University Hospital. Am I right, Dr. Di Mario?
Nearly. Careggi.
Yeah. So we are privileged to have you, sir. And I think you are speaking on how the IVL. So IVL is a new love affair with interventional cardiologists. It's one modality which everybody is liking and using quite frequently. So how is IVL impacting treatment of calcified lesions in coronaries? Over to you, Professor Di Mario.
Thank you, Dr. Kapoor. Well, I saw yesterday Professor Kastrati. Since now with these webinars, I tend to see people and cardiologists more often than my family, and it's maybe attached to you as well. And we discuss what to do. And well, you are all aware that I just presented at Europe PCR a few weeks ago, almost simultaneous with Dr. Riley, the pooled analysis, 628 patients from all the 4 disrupt trials. These are data that are available online, everybody can see, and I think most of you have appreciated the great outcome with a tiny minority of less than 4% of patients having a greater than 30% residual diameter stenosis, average post-stenting 12.1%. And you see this progressive increase in minimal luminal diameter in all these very complex, long calcified lesions. And normally, when you achieve better results in calcified lesions, you have a price to pay, like with rotational and orbital atherectomy, more perforation, more dissection, more abrupt closure, more microembolization. This seems to be almost without that price to pay. As you can see, only one perforation, but that was at the end after a very aggressive stent post-dilatation, nothing after IVL. And that's understandable if you consider the technology, as you will see in a second. We do need to improve our result in calcified lesion. You have seen before Adnan showing results still suboptimal in diabetic patients, but moderate severe calcification double the risk of target vessel revascularization. And that's not only this relatively soft endpoint that is modified, as Dr. Kastrati clarified, restenosis is not always benign. You do have associated increased risk of death, NMI, and for calcific lesions, this is definitely the case. It's a new technology, is a technology that, however, works like a normal balloon and hits the wall with extremely high velocity of 1.5 kilometer once the steam bubble is released in the half contrast, half water, half saline, and the pressure developed against the wall is greater than 50 atmospheres. However, doesn't go due to this unfocused technology beyond 3 millimeters from the epicenter. And I'll just show you some slides to indicate how these spherical area of action of the individual electrodes from which the steam bubble are generated work. These are the two peripheral balloons. You will hear more for this in the last talk from Dr. Patrone. That's the one that we use for superficial femoral arteries. There are two separate set of electrodes. The central receives then much more energy, and this is the one that we use on the contrary below the knee. That's the one that I will discuss and show in some examples. The 12 millimeter balloon, marker to marker, available in quarter sizes between 2.5 and 4 millimeter. Is important to know that the distal electrode is somewhat less distal than expected, and you will see it from the fluoroscopy. So to make it more flexible, has been somewhat put more closer to the center of the balloon, and that's important to know since you want to exert the maximum effect on the wall. And that's the reason why once you have done your first erogation, in general, you may do a second one in the same position, but then you should gently move your lithotripsy balloon backwards or forward to modify the position where the maximal energy is delivered. Of course, waiting to have fully deflated the balloon, because otherwise this can be damaged against the calcium. Occasionally, you will see not just some spikes followed by nothing, but real capture, electromechanical capture. This is not a dangerous phenomenon. No arrhythmias have been so far described, but once this develops, and normally develops in patients with bradycardia, with low heart rate, this may lead, since the atrial kick is not in phase anymore, to a drop in pressure, which occasionally can be an issue, for instance, in Lehmann disease. And from now on, following the advice I received yesterday from Dr. Kastrati, since this is big best interventional cases, I will just share some of my cases. In fact, this is a case of one of my younger associates, he sees this complex chronic total occlusion, but the target is, in this case, this proximal calcified segment of the LAD. Looks very short, doesn't believe that he needs imaging at this point. He wants to embark also in this complex CTO closure. So he goes straight for balloon dilatation at high pressure, use a balloon non-compliant, goes a bit beyond the acceptable maximal pressure, and what he gets is this dog boning effect, and at the end, rupture of the balloon without having obtained an effect on the lesion, with this no flow that was created some problems, and in fact was probably a combination of some air in the balloon and maybe some stunning secondary to that. He achieved a restoration of flow, as you can see, after some integrilin. At the end, he went for the technology that with in the hindsight you could have been chosen from the start, especially if he had done imaging. That was shockwave, and it's amazing to see that you couldn't expand at 35 atmospheres, and here at 4 atmospheres you have a fully expanded 3.2 millimeter balloon. All the pulses are delivered, and the following steps are very easy, with 2 stents with further dilatation, and with this final result that you see here, and is complemented by the recanalization of this chronic total occlusion. So this is for the people who don't believe in the technology, but let me now show a more somehow elaborate intravascular ultrasound, intravascular imaging guided case of a 72-year-old man with multiple risk factors and history of atrial fibrillation under treatment with new anticoagulants. So a patient in whom you do want to achieve optimal result, because you know that you will continue your antiplatelets just for a short while, stopping all of them probably after 6 to 12 months. And these are his blood tests, including mild troponin rise related to a crescendo pattern of angina. He has a normal left ventricular function. And in this case, we went for loading the patient before treatment unusually. So that's the right coronary artery, no critical lesion. That's the left coronary system. And you see this distal severe lesion that you will see even more prominent in the other views, while the 2 lesions in the LAD are obviously highly calcified, but their severity is somewhat questionable. What I decided to do is to go for what I felt was the worst of the 2 lesions, which is the lesion of the distal left circumflex. And after having treated that, with the result that you see here, there was no visible calcium and is a relatively small vessel, post-dilated at high pressure. I then went with a pressure wire and measured, after adenosine infusion, a FFR of 0.77. Is normal FFR, is not IFR. Is not so easy to understand which is the lesion causing most of the problem. Definitely the drop was in this area during pullback. So we went also with intravascular imaging, and in particular with OCT. Is a patient with no creatinine rise, but we have also learned from our American colleagues to use saline. The results are not as brisk, as beautiful as this, but you can do that. And let me show you the run of ultrasound. There is still some blood distal in this sort of small aneurysm at this level. Then you will soon come into the lesion in this segment, and you see how variable those lesions are, with already some calcium at this level, but here a softer eccentric plaque that will soon move to the most severe stenosis with a progression of increase in calcification, almost concentric, very thick. This is 0.5 millimeter, so it's almost a millimeter thick. And this is one of these septal branches, and we will soon move towards the left main, where the calcium will finally tend to end with a large opening with a plaque eccentric opposite to the flow divider. You will see the circumflex soon in this direction. So you see soft plaque, that's the circumflex. So that was our strategy to cover with a stent this segment after having, of course, open this thick calcification, and we decided to use a 3.5 millimeter lithotripsy balloon. These are the various points that we have illustrated. Again, note how severe, how thick the calcium is. And once you put together the three components of the Fujino means score, the one that we normally use to decide when we should perform something different from pure balloon expansion at high pressure in a calcified lesion, you see that the calcium arc was definitely greater than 270 degrees, giving 2 points. The calcium thickness approximated 1 millimeter, another point, and the lesion length was equal almost to 22 millimeters, so another point. So you have a Fujino 4. If you have difficulties to remember, Dr. Ziad proposed this rule of the 3 5s. When you have an arc of calcium greater than 50% of the circumference, a thickness of the calcification greater than 0.5 millimeter, a length of calcification greater than 5, then you should do something different than just balloon stenting. And in this case is the application of shockwave. This is the 3-5 balloon. First expansion were not complete, but was enough a single balloon with 80 erogation to obtain excellent expansion. And then we did some work also on the left main, since over there we didn't use lithotripsy. This is the outcome. And we went back with imaging, which I think is important to tell you that we have achieved our goal, which is rupturing this full thickness calcium up to the adventitia, allowing from that moment on expansion of the lesion. And I think I will show you live, if I manage, in these quite impressive images that OCT have shown, especially across the calcified segment that you see here. Still, you have this soft eccentric plaque, but please note these important ruptures in the wall without affecting the adventitia. The principle of differential cutting applies in a way to lithotripsy as well. So at this point becomes a normal procedure. So stent implantation, you don't need additional dilatation. We decided to use 2, just staying immediately distal to the bifurcation of the left circumflex. And we went, after having deployed the stent in a provisional fashion, with 2 balloons, one in the CERT that was inflated at high pressure without going too distal, avoiding dissection, one in the LAD, a 4O balloon at very high pressure, and then we went with kissing balloon dilatation of the 2 together, and with a pot with a large 5.0 millimeter short balloon, and that's the outcome after dilatation. So it looks a perfect outcome, but please note at what OCT showed at the very end. So we are now moving into that sort of aneurysm, into sort of post-stenotic ectatic segment, and then soon you will see the stent that is grossly malapposed. The rest is quite nice and has achieved a very large lumen. I don't think we have time to go through all of this, but I think I show you just the key points. You have this eccentric lumen at the level almost at the ostium of the circumflex, but with a very large lumen of 12 millimeter. But what is potentially of concern is this 0.7 millimeter distance of the struts from the wall in the post-stenotic dilatation after the end of the lesion. So we know that this is maybe not at extremely high risk of thrombosis, but it's so easy to correct. You just select, that's the opening towards the circle, that is more than acceptable, a balloon not necessarily high pressure, only large enough to pose this against the wall. And then when you do another OCT run, you manage to fully oppose that, as you can see here, without taking any particular risk. And this is the 3D image of this case. So was not much contrast because we didn't do the 12 angiogram in different views. You just have a three-dimensional OCT view, 4 pullbacks, that's enough. And I think that's the conclusion that I think this case, as well as the large meta-analysis that I've recently presented at PCR, allows you to come, is an effective and safe technology leading to circumferential fractures of deep and superficial calcium, and applicable, as you will hear at the end also from Dr. Patrone, both in coronary and in peripheral indication. My last slide is this, just an invitation, if you will not be able, because of this horrible COVID situation, to come in person, to at least connect, since this will be a hybrid edition of the annual EuroCTO Club meeting that will be held this year in Florence between 17 and 18 of September this year. Thank you.
Yeah, thank you, Professor Di Mario. About this meeting, I am in physically, so please have me in. We are looking forward for such meetings now. We are literally done with these Zoom meetings. So please register me now. Okay, thank you. It was a wonderful presentation. And now we also have a lot of experience regarding IVL, and we know it's a very handy device to get away with calcified lesions in terms of expansion of stent, in terms of getting very good outcomes. So I think still many panelists are not involved. So if Dr. Anil Dal is there, Dr. Anil, are you there? Not sure. Dr. Arun is there. I saw him. Oh, Dr. Anil is there. So any comments for IVL, or if you wish to, ask, interact with Dr. Di Mario?
Great to see Carlo, and I think IVL meets a lot of ticks, a lot of boxes for a lot of us, but very often we will have to use hybrid technologies. We will have to do rotatripsies, and we will have to consider doing laser tripsies and so on and so forth, because calcium is an enemy. And but we need to be more judicious. And I'm sure that I was a little surprised in the very elegant case which Carlo showed, considering the results of the defined PCI. Maybe you could have done a pressure wire even at the end and seen if the FFR had actually improved to something, because after all the labor that you had put in that LAD, we could have probably seen what the results were. But really, it's a very handy tool, and it's a great help for all of us in treating calcific lesions. And a great talk, as always, Carlo.
So just one question which comes to my mind, Dr. Carlo, is typically it's said that we have to inflate the balloon at 4 atmospheres only. Why can't we go to 6 atmospheres?
Well, because you don't need, because the balloon is not there to deliver pressure to the wall. this is the effect of the shock wave themselves, is only there to lead that energy towards the wall. So the only reason why occasionally I go slightly higher if is, for instance, you have a 4.2 millimeter very large ostial LED is a compliant balloon, the one we use for lithotripsy. If you go to 6, you will see is also physically larger. So that's the only case. But you don't want to take a risk by using higher pressure that the balloon ruptures and to waste the effect of a very expensive device, unfortunately.
I was coming to that. Is there a relation that if we go up on pressures, there are more chances of balloon bursting out? I mean, 6 or 7 atmospheres also.
When I'm in extremely calcified lesions and I try to do as much as possible, of course, avoiding the use of an excessive number of balloons, I maybe start at 2-3 atmospheres because the initial dilatation will obviously place the balloon against the wall once there is still a stenosis, and then I will go to nominal pressure once I see that the stenosis relieves after the sometimes suddenly effect of the lithotripsy.
Rajneesh, can I?
Yeah. I was coming to you. Yeah, please.
I think it's a wonderful device. A technology which really is of immense importance, particularly in focal calcium and deep calcium. Now, the question that I'd like to ask from Carlo is that what is its utility in a situation where you have done, for example, Rota, put in a stent, and by mistake, somewhere you have made some mistake in your judgment, and the stent has not fully expanded after putting in a stent. It has not fully expanded. Now there is a 50% residual stenosis. Now in such situations, can you then put in acutely a device like this IVL and can further treat it and can get rid of this 50% residual stenosis? What is your experience on this?
Yeah, I mean, it's not only my experience, because in fact, this is what many operators use this device at the very start. Not only once you make a mistake, sometimes you do after treatment of ST elevation myocardial infarction. You don't want, of course, to do any rotablation in this setting if possible, because there is thrombosis, contraindication. You deploy your stent, sometimes you do primary stenting and you get this extremely severe under expansion of the device. Instead of going with the super high pressure that sometimes is a gamble, why don't you go with lithotripsy? Believe me, it works very well. It does work also on stent restenosis when it's due to under expansion. Of course, you may take a risk of somewhat damaging the coating of your stent, but there are no clear reports that this leads to higher risk of late restenosis.
Yeah. So before we move on to the next one, Dr. Arun. Arun is with us. So any comments on IVL from your side?
No, I mean, first of all, thank you for having me involved, and Professor Mario, that was a masterful talk. Excellent. I had two specific questions. One was you on the OCT run, you had you brought attention to the cuts that were made. I mean, the data is kind of mixed there. I mean, how important are these cuts? Let us say you do IVL and you don't see anything visible. Does that refrain you from going ahead with the next steps, or would you go ahead and do it until then? And the second question is, I mean, given what we are trying to do with IVL, how do you pick and choose between OP and NC versus this? Does that still have a role now that IVL has kind of gone mainstream?
Well, two beautiful questions, Arun. I mean, on the first, I think now I will give a different answer than a few months ago. A few months ago, based on what we knew from our Japanese colleagues who studied the results after rotablator and high pressure balloon dilatation, they noticed that if there is visible fracture, you achieve better expansion. and less restenosis. So we assume that this was the case after lithotripsy as well. However, we had a recent series of around 100 OCT done in the DISRUPT-3 trial presented by Dr. Schlomitz at TCT last year, and he came up showing that the final expansion of the stent was the same for the around 70% of cases with visible fractures and around 30% of cases without. And there was work done in the laboratory of Dr. Virmani, both histologically and with micro-CT, showing that you always have microfractures with these devices. So I would say probably you don't have to stick necessarily to the presence of fractures. I think is impressive to show in a case like this, but is not indispensable. Your second question was about, remind me, Arun?
Was about OPN and IVL.
Well, of course, I think high pressure balloon are here to stay, and the balloon of high class like the OPN, which have no compliance, which just sticks to the size, even at 35, 40 atmospheres, I think is very important also in a way to reduce cost in a world where you also to do what is affordable. I think, however, if you can do imaging and if you can select when to apply these expensive devices, is worthwhile. And in non-concentric, in less than 270 degrees arc of calcium, definitely a high pressure balloon will achieve a good expansion. Whether lithotripsy might be even better, this needs to be addressed by new trials, because so far we didn't do that.
Yeah, thanks.
Thank you.
Thanks, Dr. Carlo. And please, I'll remind you again, don't forget to register us for your meeting. Okay, thank you. So we move further, and for the sake of time, Dr. Seth Bilazarian. So we are really proud to have him with us. He's not only an astute interventional cardiologist, he's also a vice president Abiomed. And we all know Abiomed has given us Impella, and we all know that and used Impella in certain situations which has bailed us out in very complex and challenging cases with LV dysfunctions, congestive heart failures, and it's a very handy tool once we talk of this subset. So over to you, Dr. Seth.
Thanks, Dr. Kapoor. Really delighted to be with you, and really enjoyed the lectures from both physicians in India as well as in Europe. And I'm an interventional cardiologist, practiced in Greater Boston for about 25 years before joining Abiomed 5 years ago. And I was charged with just putting protective PCI with a goal of complete revascularization as a topic today. So I think that you may be familiar with this Venn diagram. It's really something that was put together by Dr. Ajit several years ago in a CHIP white paper in Circulation. This, I think, really, I think properly contextualizes the problems that we face as interventional cardiologists. As the complexity of coronary disease increases, we're also seeing patients with significant hemodynamic compromise. And many of the things I think have been recognized, but I added this in red text at the bottom because as many patients are coming with more and more advanced medical therapies on multiple drugs, they're coming to the cath lab often with low systolic blood pressures, high EDPs, and that coronary perfusion pressure challenge, it adds to the complexity. And then, of course, the list of patient comorbidities on the far left, including surgical ineligibility. I highlight that one first because I feel like I didn't appreciate that as an interventional cardiologist myself with regard to that risk for PCI in surgically ineligible patients. And I'll show you a couple of papers about that in a moment. And of course, in addition to complex coronary disease, when I finished my fellowship 30 years ago, we were worried about mild angulation and mild eccentricity as complexity for balloon angioplasty. But of course, now we have many tools, and some of the procedural characteristics that we've become accustomed to using and are very valuable can be also challenging in this patient subset with hemodynamic compromise. heard Dr. DiMario talk about, for instance, using IVL in the issues of ventricular capture in patients as an example. Even guide extenders, which you've all become very proficient at using, can cause significant ischemia as they lay across large segments of the myocardium. And of course, atherectomy as well. All important tools, but when they're added to the mix of patients with both patient comorbidities and hemodynamic compromise, it can be very challenging. So just a couple of slides on surgical ineligibility I just want to mention. This is data from my hometown in Boston, looking at the impact of surgical ineligibility on survival after PCI. And Dr. Steve Waldo and Robert Ye published this from the Mass General Brigham experience. And after risk adjustment, these co-authors wrote that the surgical ineligible patients had a 6 times greater risk of death in hospital and a 3 times greater risk long-term. The accompanying editorial written by Dr. Kirk Garrett wrote that the CABG ineligible patients had more complex PCI, but fewer vessels treated compared with CABG eligible patients, despite similar 3-vessel disease burdens. Hence, they had less complete revascularization and hence greater residual ischemic burden. In these complex patients, I often hear a physician when I'm traveling in the US, Europe, Japan, and elsewhere, I hear physicians say, I'm just going to do 1 vessel to get this sick patient who's ineligible, through this, and then I'll bring them back for other treatments. And that is obviously a significant hazard based on this kind of data. An additional surgically ineligible data set from Michigan shown here shows again the same thing. With unprotected left main, the surgically ineligible patients had dramatically higher mortality rates and significantly worse outcomes of death, shock, new requirements for dialysis. We expect to see this data from colleagues in the US. The Optimum study will be presented at TCT, I'm told by the PIs, looking at the impact of complete revascularization on surgically ineligible patients. But they have reported their top line data at 1 month showing a mortality rate of 14%. So much higher 1 month mortality in this surgically ineligible group than we would expect in PCI patients generally. The investigators of CVAD looked at the Impella impact on unprotected left main and surgically ineligible and compared them to surgically eligible patients. And you can see that it looks like in this data set, there appears to be a risk mitigation of both death on the left and MACE on the right. When you use an Impella in unprotected left main patients, the surgical ineligible hazard does not appear to be present. And I just want to make mention, because sometimes people think about the use of an Impella strategy as just getting them through the procedure, as was said in my introduction. And that's not really what we think about it as we think about the expanded use, and we are presenting clinical evidence and have now designed the PROTECT 4 study. You can see here in the PROTECT 2 study, the randomized trial that led to the US approval of the device, comparing balloon to Impella, there's really no difference in outcomes in the first several days. And what we learned in that study, and we've learned subsequently, is that physicians, very experienced colleagues like many of the faculty on this call and others in the audience, that physicians will titrate their care. They'll actually do less with less support. So with the balloon pump patients, they got out of the cath lab, they got out of the hospital. But that difference in what they did, less atherectomy, less optimization of stents, ultimately accrued over time to more MACE over 90 days. And so some things that we've learned from the surgeons, or I've learned from the surgeons, because surgeons have more fully integrated pumps into their practice than interventionalists, in my estimation. All the technology that we use, surgeons are not familiar with. All of the techniques and tools that were presented today, surgeons don't really know, except for pumps. They have more experience with hemodynamic support than we do. So a couple of things that I feel like they've learned, I just want to highlight. One is that on-pump revascularization provides superior outcomes to off-pump at 1 year. If a surgeon does an off-pump CABG, the patient has a shorter length of stay, they have shorter times in the hospital, and less ventilator time and less strokes. The problem is that 1 year, they have higher death rates and less graft patency. And I use this as an analogy to think about off-pump versus on-pump revascularization with high-risk PCI using an Impella-supported strategy. The second comment that was made also in my introduction, from Dr. Kapoor, I just want to highlight, is that a bailout strategy is really hazardous. The surgeons know that the risk for bailout from an off-pump to an on-pump surgery is 3 times greater mortality risk. And recently published in CCI just last week is the bailout use of Impella. The mortality rate with a bailout strategy in high-risk PCI is 10 times greater than a planned on-pump strategy. In cardiogenic shock, unload the ventricle first and revascularize. I won't go into greater detail with that. Complete revascularization optimizes outcomes. I think we all recognize that, but the highlight here is that in these high-risk patients, it's even a more exaggerated benefit if we do complete revascularization compared to all comers. These patients with low EFs, with left main intervention, they have more impact of complete revascularization. In achieving that is harder, but the benefit is greater. And last, I'll just make mention in yesterday's presentations in this conference, there was some comments about weaning. Weaning from support after revascularization is really important. When a patient's on an Impella support, we've seen, unfortunately, some bad outcomes when the device is taken out promptly at the end of the case. And the surgeons know this as well. Weaning is part of the procedure. When an impaired ventricle goes through the ischemia-producing strategies that we submit them to, atherectomy and left main stenting, they may need a longer time to recover, may need 4 hours or even overnight support before the device is removed. So a couple of just comments that I think are known about complete revascularization. In an all-comers registry in Sweden, I just think fascinating data defined by complete revascularization at the time of discharge from the hospital. Really impressive differences in complete versus incomplete revascularization in death. A 4% absolute difference in mortality, revascularization, MI, and all of the composite endpoints favor a complete versus incomplete in this all-comers registry in Sweden. When you look at patients that are more typical of a protected PCI or high-risk patient population, I think that the data published by Dr. Sripal Bangalore from NYU, looking at the New York registry, a real-world evidence registry, compared modern DES to CABG in patients with a low EF, so EF's less than 35%. And very consistent with all other trials that there's similar death and higher MI with PCI, lower stroke, and more repeat revascularization with PCI. The most fascinating part of this paper was actually in the supplement. When you look at this data at the top of all comers, 3 vessel disease comparing stents, the event rate was 11.89% at 4 years versus CABG 3%. In 2 vessel disease, 10 versus 6. When you look at the complete revascularization patients, however, the stent patients actually appear to do better, 5.7 versus 8.4% at 4 years. But the incomplete was very bad with stents versus CABG. So really highlighting the importance of complete revascularization in low EF patients. Again, all comers data, looking at when you compare DES PCI with complete revascularization, it's equivalent to CABG, but then this is in all comers. Again, focused on the higher risk patients, this effect is exaggerated. And then published just this morning in JACC in the US was this data from Syntax looking at the 10-year follow-up of revascularization in elderly patients with complex coronary artery disease. And when you look at the patients who are greater than 70 and the patients less than 70, PCI versus CABG, you can see the elderly patients did have higher death rates as you would expect in an older population compared to the younger patients, but no differences in CABG versus PCI out to 10 years. And again, I remind everyone, this is Syntax using older PCI methods and of course, paclitaxel-coated stents. So again, we would expect to do even better now. But one part of the paper, which I think was very interesting, I'll highlight, is that the residual Syntax score was low in all, but the number of patients that had what we consider to be adequate complete revascularization, residual Syntax score less than 8, 1 in 5 patients in the older patient group did not achieve that adequate complete revascularization. So still an opportunity for improvement. And I think that probably if you look at all comers registry, not those randomized in a paper trial like Syntax, the residual Syntax score is likely to be much higher. So in those patients that you see and the ones we presented that we saw presented yesterday, much more complex patients are being treated in the real world. And of course, when we think about patients that are coming for revascularization who may have had prior CABG, we know that repeat CABG is a very significant risk, especially in elderly patients. And a patient who's over 70 with previous CABG, their preoperative risk right out of the box is greater than 5%, just being 70 with prior CABG. So there's all these other risk factors, of course, for CABG as an important risk factor. And the Cabbage syntax score was developed just to look at that. Is it important when we do PCI in a patient who has prior Cabbage? And again, the same message. A high Cabbage syntax score post-PCI is correlated with worse outcomes of MACE, death, all-cause death, and any revascularization. So we really have to make a commitment to doing better, more complete revascularization. Now, some of the technical considerations to achieving complete revascularization are important, especially again in these lower EF patients who have these comorbidities and these issues like surgical ineligibility. Left main treatment with requiring IVUS or OCT, as we saw today, Dr. DiMario highlighted this, and a double kiss crush strategy are important techniques, but they have not been really investigated in a careful way in this lower EF patient population. We also heard about using intravascular lithotripsy, which requires longer inflation times. Again, a challenge in patients that have a low EF, as well as drug-coated balloons, which require 30-second inflations to achieve drug delivery. And of course, CTO treatments, when we're going from a donor vessel to a collateral recipient, are important. When we do rotational orbital laser atherectomy, these are all challenging issues with regard to impact on patient outcomes in the lab and for achieving great revascularization. I highlight, of course, Dr. Greg Stone, who did the very important Excel trial and showed gives us confidence that left main intervention is equivalent out to several years compared to Cabbage. But I will highlight that this was in normal EF patients, and the hemodynamic support use was very low in this patient population. So again, this data is important, but can't be applied to lower EF patients as an important message to everyone. And just another message as we think about it, we've become very comfortable using devices. Rotational atherectomy has been around for a number of years, but in the instructions for use for rotational atherectomy, it gives caution about using it in patients who are surgically ineligible or who have 3-vessel disease or have unprotected left main or EFs less than 30%. All of those patient populations are the ones we are actually using atherectomy in that are higher risk. And how do we mitigate the risk? And of course, one strategy is to use an Impella-supported strategy. So to briefly show you some data from presented at TCT and now in press is the PROTECT 3 real-world evidence, looking at patients from 2017 to 2019 using an Impella-supported strategy. So Dr. William O'Neill, the study chairman, wanted to say what happened from PROTECT 2, which was done between 2010 to 2007 to 2010, to this more modern cohort in the real world of patients in PROTECT 3 who are like PROTECT 2 and had similar inclusion-exclusion criteria. And you can see these patients were older, had more women, they were less Caucasians. They had many high-risk features, including surgical ineligibility and prior Cabbage, and similar mean arterial pressures of 88 and EF of 23%. And in this data set, you can see that the length of support was longer in PROTECT 3. Again, this modern understanding that we have to support patients for longer. If you look down here, I think you'll see that in PROTECT 2, the patient that left the cath lab was 1 in 18 in PROTECT 2, and in PROTECT 3 is 1 in 7. Still a minority, but this recognition that patients may need longer support in these impaired ventricles. 3-vessel intervention was 31%, left main intervention 43%, and atherectomy use was 37%. So really high-risk procedures, complex procedures. Lesion length, calcification, was all important. And the change in the syntax score was much greater than the PROTECT 3, so they achieved more complete revascularization. I mentioned the delta here is shown in PROTECT 2 was about 15, and here was about 21 in the PROTECT 3, but they also achieved a lower residual syntax score. I mentioned that residual syntax score of less than 8. They did not achieve it in PROTECT 2 10 years ago, but in the modern group, they did on average get to less than 8. And so here's what Dr. O'Neill wanted to answer. And you can see out to 90 days, you can see that PROTECT 2 balloon pump patients compared to the PROTECT 2 Impella patients, compared now to this more modern group of PROTECT 3 that are PROTECT 2-like, showing this improved outcomes to 90 days. And this really informed trial design for the PROTECT 4 randomized controlled trial. So in PROTECT 3, this was the largest prospective study of Impella in high-risk PCI. And compared to the 10 years ago data from the randomized trial PROTECT 2, the patients were older, had more comorbidities, complex lesions, and more extensive revascularization. The MACE was better, and the safety was also better with better vascular and bleeding complications. One of the impressive things that have happened with the use of the Impella is that you can see in each of the 3 years of the PROTECT 2 data, the bleeding rates went down every year. But then in our real world data collections and other data sources, you saw this continued improvement in major bleeding. And I've presented you the data from PROTECT 3, which shows an even better major bleeding rates in this modern era using best practices and innovations and technologies. So that has led now to PROTECT 4, a randomized controlled trial, which we have just begun enrolling in, looking at EFs less than 40% with chronic coronary syndromes or NSTEMIs, with PCI with Impella support before and 626 versus those with PCI without planned hemodynamic support with follow-up out to 3 years with MACE and hospitalization. We've just begun this in the United States with plans to do this both in the US and in Europe. And it was announced by Dr. Greg Stone, the study chairman, and Dr. Amir Kaki, who was the first to do this case, first patient. So my conclusions are here that there's the growing population at cath lab of both heart failure and elderly and CABG eligible patients are growing. Complete revascularization improves outcomes and has a greater impact on higher risk patients, including improvements in quality of life, readmissions, and cost of care. And the protective PCI approach in high-risk patients is really a valuable skill. This enabling technology of hemodynamic support allows physicians to improve lesion treatment, to optimize stents, and do debulking as needed, and also allows complete revascularization. And that's demonstrated impact on MACE to 90 days in both PROTECT 2 and PROTECT 3. And we plan to continue to show that again in PROTECT 4. So thanks, Dr. Kapoor, for including me today. I'm delighted and be happy to take any questions or comments.
Yeah, thank you, Dr. Seth. It was really, really nice. It was wonderful and very, explanatory in its own way. So Impella, we know, I'll just give one comment. We're running late, so we'll go to the next one. Just one comment. In our initial days, once we started using Impella, we were weaning it off into the recovery area, not into the cath lab. And we faced many problems. The outcomes were not really great. But then with a learning experience, we learned to wean it off after the procedure. And that gave us an impetus and outcomes got better. So any of your comment on that, and then we move
Sure,
on.
Dr. Kapoor, I think that's a great comment, but I think the way to achieve both goals, to get longer hemodynamic support, is to bring patients back to the cath lab. So what we have learned, and I didn't share best practices because of the limited time, in every one of our trials, we have a STEMI trial, we have PROTECT 4, we have a shock trial. It's required to bring patients back to the cath lab because we believe that gives us the best options for balloon tamponade, for up and over completion angiography. So do what you were doing before, send patients out to the recovery area for several hours or even overnight in the ICU, but bring them back to the cath lab for device removal to optimize the vascular and bleeding complications.
That's a good tip. Thank you. Thank you. For the sake of time, I think I need to move forward. Although I wish to involve panelists, I think I'll involve after this talk a few panelists who are still not involved in the discussions. So I move on to the next one. We again have a very elite speaker from UAE, Dr. Hussein Heshmat Kassem. He's an interventional cardiologist and professor of cardiology from United Arab Emirates. So it's nice to have you, Dr. Hussein, and over to you for your topic on ultra high pressure balloon angioplasty. Please go ahead.
Thank you so much, Dr. Kapoor. I'm actually honored to be here among this wonderful group of international experts whom I used to learn from in the conferences and in their cases. And I'll be taking the thread from where Dr. Bilazarian and Professor Dimario ended. I'll be talking about the pressure versus arterial stretch and the use of ultra high pressure balloons in coronary angioplasty. So we all know that PCI is getting more complex. We're seeing elderly patients, sick patients, calcified lesions, poor ejection fraction. And for example, where I practice currently, it's regular to see patients in their 80s and 90s. We try to push them towards the conservative side, but when present with ACS, then we have to do them. And I know there have been so many advances in the stent technology in the last 2 decades, but we still see stent failures in approximately 1 out of every 8 stents, either in the short term or on the 5-year duration. 1 out of every 8 stents would fail, either with restenosis or with thrombosis. And when we look at the intravascular imaging and we try to understand what's happening, we find that the minimal stent area is one of the strongest predictors of both restenosis and thrombosis. Whether it is early or late, malapposition and under-expansion are seen in somewhere between 40 and 60% of stent thrombosis. And looking at in-stent restenosis with IVUS, intimal hyperplasia is of course an important factor, but a minimal lumen area of the stent less than 5 or 5.5 is implicated in somewhere between 20 and 40% of restenosis. So our stents are better, are improved, but we need to prepare the lesions before we put our nice stents. And we also need to optimize these stents after they are implanted so that we achieve the bigger and the better lumen so that we reduce the chances of stent failure down the line. And now as technology has advanced, we have many options, many devices, and now it takes a real physician with wisdom to choose based on his situation, where he works, the economic situation, which of these devices is the best. We have laser, coronary IVL, rotablation, orbital atherectomy, and many other devices. And each of these devices, if we want to classify them, then some of them are balloon-based, some of them are catheter-based. Balloon-based devices aim at generating pressure, and this pressure, when strong enough, it will break the calcium. Rotablation orbital, they work with kinetic energy. Laser works with photoablation, which dissolves the calcium into bubbles. And this matrix may be complex, but this is my own understanding of the advantages and disadvantages of each of the devices that we currently have. And after several years of working with calcified lesions and understanding the pros and cons of each device, these are all nice devices and they are nice to have in any cath lab. But my opinion, what I learned is that the essential devices, the ones that you must have if you're handling calcific lesions, is combining rotablation and an ultra high pressure balloon. Because rotablation has the best crossing ability. The efficacy is somewhat limited when it comes to deep calcification. It needs a learning curve and it's expensive. We'll go now and explain more about the OPN and why I would like to call it as a must-have in any cath lab that's handling calcified lesions. So we'll be discussing four aspects: the design of the balloon, and why is it different? What evidence do we have from randomized trials? Where do we use it clinically? I'll be giving some quick examples for the sake of time. And my last slide will be on the 10 commandments for the technique of using the OPN. So we'll go one step backwards and explain the basic concepts of balloon angioplasty. What's the difference between a semi-compliant and a non-compliant balloon? And the difference here is between the volume and pressure. Semi-compliant, or let's say compliant balloons, they are able to expand whenever we put any pressure inside them. So they occupy more space inside the vessel. Whereas non-compliant balloons, as the name implies, they do not comply. They just would reach their preset diameter, even if you exceed, even if you put more pressure inside them. And it's the pressure what we actually need to break the calcium and to fragment the plaques. It's the pressure that we need. It's not the volume. So for example, if you use a semi-compliant balloon and it doesn't open the vessel, the biggest mistake that you can do is to take a bigger balloon. Because the bigger balloon, when you apply some pressure to that balloon, you'll see the dog boning effect. The balloon will expand into the areas that are not calcified. Whereas the areas that are calcified and bear the largest plaque burden, they will not expand because, and the pressure will be transmitted into the sides, into the healthy, relatively healthy areas, and the end result is big dissections and perforations. And I would like to give you the small example. If you have a 4 millimeter vessel and you put a 2 millimeter balloon and you inflate that balloon to 80 atmospheres, then probably nothing will happen. The vessel will not rupture. But if you take the same 4 millimeter vessel and put, let's say, a 6 or an 8 millimeter balloon, and you inflate that just to 2 millimeters mercury, the result will be a big dissection and maybe a perforation. So we need to focus on building high pressure without increasing the volume. This is the thing, this is the way to break the plaques without breaking the vessel. So the way to go is by making our balloons less and less compliant, going, as Dr. DiMario said, towards zero compliant balloons. Because when we do that, we'll be able to generate a very high pressure, enough to break the calcium, without filling the vessel unnecessarily and stretching the vessel unnecessarily and taking the risks of rupture. And the concept of pressure is not just for the OPN balloon, it's there for the IVL balloon. This is from the instruction for use for these are the instructions of use for the IVL balloon, and you say, and it says here that the pressure waves, the ultrasound waves, are eventually giving an effective pressure of 50 atmospheres. So again, we're back to the concept of pressure versus volume. So what's different with the OPN balloon? The most important difference is the twin layer, the twin layer construction, the double layer where the balloon is designed. This allows the balloon to tolerate very high pressures, 35, 40, and even higher, without the balloon exceeding its volume. We'll show the compliance chart. And the magic word here is the uniform expansion. I'll show you some of the angiography cases, and you'll see the balloon, even in the toughest situation, it's able to expand in a uniform manner without any dog boning. Therefore, the chances of vessel injury are significantly less than other kinds of balloons. And here's the compliance chart. If you take any diameter, the nominal pressure is 10, and the rated burst pressure, as the company would like to call it, is 35, but I know that we can go higher. Looking at any diameter at the nominal and the maximum diameter at 35, you'll see that the difference is only 10%. So you can say that this balloon is almost 90% zero compliance. The maximum pressure would bring it only 10% higher than the nominal diameter of the balloon. And how does the OPN compare to the other available non-compliant balloons? They all have steep compliance curves, so they don't grow much. But the OPN is able to go a couple of extra miles, because the other balloons are able to tolerate only up to 20, 22, whereas because of the dual reconstruction of the OPN balloon, it's able to tolerate higher pressures without a significant increase in the volume. And we tried ex vivo, outside the body, of course, to inflate these balloons with their special inflation device up to 40 and 50, and they don't rupture. And each balloon is tested in the factory that if you go up to 45, it will not rupture. So the end result is a uniform expansion with no dog boning and no rupture. And revising the evidence for the use of this balloon, we'll take this nice study that tested the high pressure balloons, not for stent optimization, but for pre-dilatation, for lesion preparation. And it compared using a semi-compliant balloon with high pressure balloons in different situations, including the late scaffold. And the result, of course, that the instant minimal lumen diameter was better with the non-compliant high pressure balloon, and the stent expansion index was better in the non-compliant balloon without having excess risk of vessel injury or perforation. But the interesting finding here that I would like to shed some light on is that if we go with the semi-compliant balloon and we go ahead and place the stent, and we discover that the stent is underexpanded, and we try to correct that with a non-compliant balloon, there's a big chance that we fail. So looking at the expansion index after stenting and trying to correct that in the final with an NC balloon, then there's a big chance that we may not be able to expand the stent. So this highlights, if we do that with a high pressure balloon, of course, If we use the high pressure balloon for preparation, then we stent, and then we use it again for stent optimization, then there are bigger chances that we will achieve a better expansion index. So that's one advice, is to use these balloons for vessel preparation, not just for stent optimization. And this study by Dr. Di Mario and his colleagues, where they tested the situation where you go for a regular balloon and it doesn't expand, and then you go for the OPN balloon. And used in stent optimization in 40% calcific lesions, and you can see that the final pressure is on average 37. So there's a very easy chance that you cross the 40. And you can see that the diameter here is not as big as we used to expect. And I'll explain that as we go on. And despite going to 37 atmospheres, there were no coronary perforations or vessel ruptures. The angiographic success was 92%, and the failures were mostly due to failure to cross, because this device is a bit bulky, and I will give some advice on how to optimize crossing with the device. And comparing the OPN to the non-compliant balloons, in all the parameters, the diameter stenosis is better, the acute gain is better, and there is almost always an incremental gain over the NC balloons of somewhere around 1 millimeter. And the incremental gain here, the OPN is in red, in reducing the diameter stenosis, is more or less consistent whether we're using it for calcific lesions, for stent optimization, and probably in the in-stent restenosis, we're able to get the best incremental value compared to regular non-compliant balloons. So it works in calcific lesions, in vessel preparation, in stent optimization, whether the stent is just deployed or whenever there's in-stent restenosis. Another important trial is the ISAR-CALC trial by Dr. Kastrati and his colleagues, where they randomized patients into using the super high pressure balloon or the scoring balloon. And they found that there is a strong tendency for the high pressure balloon to achieve a better diameter reduction and a better minimal lumen area compared even to the cutting balloon. Keeping in mind that the cutting balloon has always the risk of being trapped inside the calcific lesion because of the wires or the nitinol elements. So we use these balloons in my lab for patients. For example, this lady with end-stage renal disease, the NC balloon is not opening. So the reflex that we have is to go in with the OPN balloon, and we didn't have to go to 30 or 40 atmospheres. You see the uniform expansion just at 12 atmospheres, and we had to optimize again, and you see the final result. This gentleman, whom we used an NC balloon a couple of years ago, because the NC balloon didn't open. You see the dog boning effect with the in-stent restenosis, probably a mix of calcium and fibrous tissue. At that time, the scoring balloon worked. He came back a couple of years later, just last month, with restenosis again. And you can see the cutting balloon, which worked last time. Here, it's not working, and you see the dog boning. We placed an IVL. We had some gain in lumen, but we still had some indentation with the NC balloon. So we went up with the OPN, and you see the best uniform expansion that we got was with the OPN balloon. And here comes the final result. Again, a 90-year-old lady with high-risk non-ST ACS, and her LAD is a tube of calcium. You can see 360 degrees calcium all along the LAD. And because we need to make sure that we'll be able to deliver our balloons, so we go with the rota to create a lumen. But as you can see, even after we did the rota, going up with an NC balloon, we see the dog boning because of the residual burden of calcium. The rotablator created a crack, but there is still a burden of calcium, which the OPN didn't do. We went with the IVL, we achieved some expansion after 4 pulses, and we deployed the stent in the left main. We did the optimization, but you see we had some under expansion again in the ostium of the LAD. The minimum lumen area is 4. And in these, we used the OPN. We didn't have to go to 4. We just need to achieve a minimum lumen area of 6 millimeters, 5.5 or 6. So an OPN 3 millimeter is usually enough to do that. And we gained extra lumen from 4 millimeters to 6+ millimeters squared. And this is the final result. We also use it in peripheral angioplasties. This is an off-label use, but whenever we go on with a balloon in the distal SFA, this patient had 2 layers of stents and the balloon is not opening. You see the classic dog boning. This was a 5 millimeter balloon. We went with the IVL balloon. It gave us some lumen, but you see again the uniform expansion that we see with the OPN proximal and distal is unmatched. And only then we were able to expand a big volume with a drug-coated balloon and open the lesion, and that was the final result. So how should we use this balloon to the best way possible? We need to respect this device. It's not just another balloon that you throw in and you go up to 40 or 50 atmospheres. You need to take into consideration the entry profile of the balloon, the stiffness of the dual layers that are giving the balloon the ability to tolerate the big pressure, the high pressure, and respect the diameter of the vessel and the diameter of the balloon. So these are my own 10 commandments for proper use of the OPN balloon. These devices are high profile, so they need proper guide support. You need a nice wire, a supportive wire, preferably the Grand Slam, to be able to deliver the balloon. Avoid using hydrophilic wires because once you inflate the balloon to high pressure, they tend to get sticky to the wire. So whenever you try to take out the balloon, you may take the hydrophilic wire out with you. So a Grand Slam wire to me is the best wire to use with the OPN balloon. Careful attention to preparation. If you are worried about rupture, which we never had in 100 uses, then the rupture, the problem is that the air and the jet effect, the air would worsen the jet effect. So I never had a rupture with the OPN, but this applies, of course, to any balloon. Whenever you have air, then the consequences of vessel damage would be higher. Careful attention to anticoagulation. We are exerting pressure. We are cracking the plaques inside the vessel. So if the patient is not properly anticoagulated, you may end up in an abrupt vessel occlusion. And the most important point is when you're optimizing the vessel after the stent, which diameter should you take? And perforation is not related to the pressure. People are intimidated by listening to numbers like 30 and 40 atmospheres. But I assure you, it's not the pressure that will cause the injury. It's the balloon diameter that will cause the injury. So base your choice of the balloon according to the lumen that you want to gain. It's not based on the external elastic lamina of the IVUS because you must respect that there will be a plaque. We will not take the plaque out of the vessel. So give some room to the plaque and target your balloon based on the lumen that you want to use. We usually don't exceed 3 or 3.5 millimeters. Stop at the pressure where you see the uniform expansion. As the patient I showed, if you achieve uniform expansion at 10 atmospheres, that's well and good. Then there's no need to go for higher pressure. Start from distal to proximal because once the balloon is inflated, it doesn't fold back again easily. So reusing the same balloon again might be some of a challenge. So these are my opinions on using the OPN balloons. Thank you so much for listening. And I hope I made it clear and we can take questions if you want, of course.
Yeah, Dr. Hussein, it was really nice. It was really nice. You elaborated all the points regarding the usage of OPN and tips and tricks. So it was really informative. I think we are running quite late in the night, and I can have one comment from Dr. Mahesh Basarge. I think, is he here? There are a few panelists who have not been, still not
Yes,
been.
sir.
Yeah, Dr. Mahesh.
Thank you.
So,
Yeah.
So one comment on,
I think,
yeah.
Dr. Hussein, it was a very nice presentation, and most of in your final, conclusion, you have commented for the commandments, what precautions we have to take. So what is your suggestion for, preparation of the lesion pre-dilatation with non-compliant balloon first, followed by OPN balloon, or directly go with the OPN balloon?
If you suspect that the lesion is tough or you see some radio-opaque shadows suggesting calcification, then I would go with an OPN from the start. I'd like to save it because I don't have enough stock all the time. So we like to use it judiciously for lesion preparation.
Yeah, thank you. Thank you. For the sake of time, we're moving ahead, and we have further, Dr. Lorenzo Patrone, who's a consultant interventional radiologist, and he hails from London, Northwest Healthcare NHS Trust. So thanks for being here, Dr. Lorenzo. It's lovely to have you. And I think you are giving us a talk on tips and tricks while using a peripheral intravascular lithotripsy.
Thank you so much for the invitation. It's a bit strange for me to be in a cardiology congress. I was honored to listen to your talks. Very interesting to see another world compared to mine. So as you can see, essentially from the title of my presentation, I mainly do, of course, I'm an interventional radiologist, so I deal with peripheral disease. So today my task is to show you tips and tricks for peripheral use of the shockwave catheter. And, I will start saying that, for all the great tricks, there's always an explanation. And I want to show you why sometimes, shockwave is really, really helpful in our world. So first of all, the first suggestion, tip is know the technology. So you need to know how the shockwave works. So essentially, as it was said also before, it's important to know that it's a catheter which it's mounted. There's a balloon and there are some which makes these waves, and these waves are very focal and very specific. Points where the balloon will inflate to a potential 50 atmospheres, as it was said in the presentation before. And so it has a very localized effect on both the intimal and medial calcium. And if you look at of course, the effect it does on vessels. So some people say, okay, what does it make to the calcium? Where does the calcium go? So essentially the calcium doesn't go anywhere. The calcium is cracked by this technology, and you can see here in a very impressive for me anatomopathological section that the vessel has been sort of intentionally damaged, and the calcium is cracked. And this will then, of course, permit you to have a better dilatation after, or even if you want to stent segments like SFA or TP trunk, then the stent expansion would be far better than with a normal vessel preparation. So I also want to stress, like it's hard on hard. So essentially the balloon works very well on the calcium, so where the electrodes are. And when you inflate the balloon just cracks the calcium, because you see here, this is the signal which is made by the balloon, and the calcium just cracks after a few shots. And you can see on the opposite, instead, it's soft on soft, means like it acts very precisely and very effectively on the calcium, but it leaves all the other tissues, like the fingers of the operator here, completely free from any kind of insult. So it's very safe, and also gives especially in the peripheral arterial disease, doesn't give any kind of sensation to the patient, which actually is very comfortable on the bed. So if you want to know also after you know how the system works, you need to know how it works in real life, in literature. Essentially, there's a very large body of published evidence, and actually there are more than 40 peer-reviewed publications with more than 1,600 patients which are enrolled for different kind of usage of the intravascular lithotripsy. It could be the iliacs to permit for you cardiologists especially to bring up big devices. It could be the common femoral, just to avoid the stenting or to permit a better expansion of the stent. And of course, the most known topic is about femoral popliteal and below the knee. I will show you that, of course, this is something that you know already. It's a safe and very effective way to treat iliac arteries in case you want to do an EVAR or you want to do some cardiac catheterization. But also, there's a very good study which disrupts paid did 3 study, which came out last year, the results, and it shows that in SFA, of course, and popliteal lesions, the intravascular erythrotypsy cause a low residual stenosis, high acute gain, and low rate of complication, despite the complexity of the disease. And this is something that I want to stress, because usually, this is a study which is a Disrupt PAD3 randomized control trial. Essentially, this is a randomized control trial done on lesions that usually people don't include in their trials. So the lesions which have a medium to severe amount of calcium, which is, as the same as the coronary is the worst enemy of our treatment. So if you look at that, and also it's not just randomized, it's also the fact that there's also a rigorous core lab adjudication. So that means that someone else from from the operator judges the results. And actually both suggest that procedural success is higher compared to normal PTA. And if you look at the data, there are many data, of course, which came out, but I want to stress 2 in particular. There's less 75% reduction in provisional stent placement risk with IVL. So it means that if you use IVL, there's 75% people less that require a stent. At the same time, there's a less 77% of people with a dissection, which could be fatal then for the long-term patency of the vessel. So these are very impressive data from a randomized control trial. And after you, of course, the data, you also have to know your patients. You need to know your vessels. And the normal tolerance, this is a very nice paper which came out last year. And it shows probably, as an endovascular operator, we are many times undersizing the size of the vessel. So essentially the SFA has a median diameter of almost 6.5, where the popliteal artery has higher than 5.5, almost 6 millimeter. So always remember to size the vessel correctly. For example, let's see this patient which I had, which has this kind of very calcific vessels. You can see how the patient is a diabetic and on dialysis. You can see how the arteries down to the leg, despite the very young age, are like a tube of calcium. So this patient came on table. You can see here on the angiographic images how the calcium is imprinting the vessel, which is quite large anyway. And you can see here, especially there, how tight and severe the calcified stenosis is. And here it's also 2 different lesions at the level of the undercanal and popliteal level stent. So essentially, it's a good trick. Like this balloon, it could be quite difficult to advance on its own. So a good trick is to inflate a smaller size balloon into the vessel in order to prepare the vessel then to be crossed with this 014 IVL balloon catheter. You can see after pre-dilatation with 3 millimeter how the 7 millimeter shockwave balloon crosses. And now I want to stress again, it's a 7 millimeter balloon. This balloon is inflated at low atmospheres. You can see here how it just inflated between 2 and 4 atmospheres. And you don't need to, push on the walls of the vessels. You just need to have a good contact with between the balloon and the vessel wall in order to crack the calcium, as we have seen before in the anatomical pathological scan. Then, this is again, I'm going with a 7 millimeter balloon, even lower at the level of the undercanal and even at the level of the popliteal artery. And inflating at very low atmospheres, like 2 to 4, the risk of rupturing the vessel is extremely low. So look at the final result, the final result without any type of stenting. You can see how the vessel now is completely patent with a good vessel diameter. And if you look even at the popliteal, there's a complete clearance of blood flow into the anterior tibial and peroneal artery, as the patient probably had when he was very, very young. So it's not just about as I said, the popliteal, the SFA. It's about also the BTK vessels. There are new catheters made for this purpose. And again, the sizing is extremely important. And this I want to stress. So you see here, this is a 77-year-old gentleman with ulcer of the 5th toe. You can see how the TP trunk is extremely stenotic and calcified. The TP trunk, of course, gives 2 important vessels, the posterior tibial and the peroneal. You see, I open with a 2 millimeter balloon, a little bit of space for my IVL catheter, and you can see the amount of calcium which is around this vessel. And you can see I'm using now a 5 millimeter balloon for this lesion, because, you know, as I said, the lesion is between 4 and 5. I inflate the balloon at very low atmospheres, and you can notice how the balloon step by step starts opening without, you know, inflating at higher atmosphere. Just different cycles of this technology permits the calcium to crack and then to expand the balloon even more. Look at when I use, after the preparation with this 5 millimeter balloon, I use a 4 millimeter balloon to finish my angioplasty with a normal 4 millimeter with a normal pressure. You know, it completely expand, you know, against the very high amount of calcium. And if you look at the image which I obtained later, you can see how the patency of the TP trunk now is remarkable without the use of any stent. And you can see here that just the dilatation of this small segment of the TP trunk completely changed the appearance of the foot. You can see different before, of course, and after our angioplasty, same amount of contrast, same frame rate. You can see the difference at the level of the ulcer, at the level of the fifth toe. And it's not, again, just about the angiographic image, it's about the foot of the patient. You can see how the foot, which was not healing with 2 big ulcers there, completely healed after 3 months, which is very remarkable. And if you look at the last part of my presentation, is about the common femoral artery. It's something that usually people are scared about. It's where the surgeon takes his pride and, you know, and open the artery, remove the plaque and put a patch. And this is not an operation which is completely without complications. You can see here this gentleman, 67-year-old, rest pain. And the profound femoral artery was patent, but, you know, the common femoral artery was diseased. You can see here the amount of calcium at that level, which you can correlate even better with the angiographic images. So you can see here we inflated the biggest balloon that we had, the 7 millimeter, just again to crack the calcium at that level, because the vessel was 10 millimeter. But what you need to do, you need to crack the focal calcium. So 7 millimeter shockwave, then 10 millimeter normal angioplasty. And by doing that, you obtain a fantastic result with a very great flow. And I want to show you before and after. These are very hard rock of calcium inflated, which would have prevented the inflation of a normal balloon at 10 atmospheres, would have caused dissection. But by the use of the normal, the shockwave balloon 7 millimeter plus the 10 millimeter, then you have a vessel which is patent at 10 atmospheres, but with no dissections, because we were more gentle despite the high amount of calcium. And of course, everyone wants to be the good guy, leaving nothing behind, but also sometimes you need to scaffold. And this is the case of another common femoral. You can see this kind of ghost of the calcium into the artery with the SFA occluded. So we needed to do something for this patient. You can see how the calcium is very much causing the stenosis inside the lumen for this patient. And you can see how to cross the lesion was not that difficult. You can see how my O14 wire goes pretty easily into there, but you can see, you can appreciate the amount of calcium at that level. And we decided to inflate the 7 millimeter shockwave, even going into the profound femoral artery. You can look at the bifurcation, how calcified it is. And actually, again, you can see how the balloon, step by step, after different cycles, inflated and created a better space. After that, you can see even the normal balloon angioplasty, because we talk about, how easy it is to burst the shockwave balloon. The shockwave balloon is very thick compared to other balloons. And actually, after a normal angioplasty, finally we got quite a good result, but we decided to stent. We use the Supera stent, which is a stent which is very good for the purpose. We deployed, you can see how the stent is deployed completely nominal, like in your coronaries. And you can see how, the lumen gain is very good, even on the angiographic images, but even more when you see the leg bent by the patient on table. You see the stent is not impressed by the calcium. There's no compression. You can even see with the injection of contrast how the lumen is completely preserved with no impression of the calcium on the stent, on the artery. So also we can discuss about is shockwave a definitive treatment of vessel preparation? I mean, we can be probably open to both the options. The only thing we need to know is it works very well in cracking the calcium. And once you have done that, then you can really do your best with a normal balloon or a normal stent. And just to finish, my presentation, I just want to mention what the Patch Adam says. It doesn't matter how you treat the disease, because you treat the disease, you win, you lose. But always remember, that if you treat a person, I guarantee you, you will win, no matter what the outcome. And with that, I thank you for your attention.
Thank you, Dr. Lorenzo, for a very nice presentation on peripheral vascular disease. And I think we can have one question for Dr. Lorenzo. Maybe Dr. Sridhar, are you there? Do you have any questions for Dr. Lorenzo's presentation? Sridhar there. Is Dr. Oomen there? Dr. Oomen, panelists? Okay, so I think this is a fantastic way of treating peripheral vascular disease. And I think that you're taking the next step of how to treat calcium in the peripheral vascular disease. How often do you avoid stenting now because of this technology?
It's a very good question, actually. I started using Shockwave a few years ago, and now I have to say I stent less and less. So essentially, even the data of the randomized control trial, which came out, of course, the one at 30 days, the first 6 months, sorry, are very much showing these kind of results. So there's 75% less stenting compared to normal balloon angioplasty. So I have to say that probably I'm not 75, but I would say between at around 60 less. And actually, this is a great result, because especially when you open a stent in a coronary like you do, I mean, the stent is short, there's a high pressure, so usually the stent stays open. If you open a stent in the SFA with a patient with cardiac failure and all this kind of disease, the chances that this stent can go down are far higher. So the less we stent, I think the better is for the patient. So, and Shockwave, became my, a very good tool for me, even for the BTK segment, because I mean, there are vessels which are extremely calcific, and 2.5 and 3 millimeter and 4 millimeter balloons are very much useful in my practice to tackle also BTK disease.
Thank you, Dr. Lorenzo, for a nice lecture. And in the interest of time, we go to the last presentation.
Thank you.
Thank you. And we call on Dr. Ravindra Rao, who's one of the most prolific valve deployers in India. He's a large experience both in this country, and he will talk to us about the unmet needs of TAVR. So Ravindra, he's now the chairman of the Rajasthan Group of Hospitals, and we can have Ravindra to give the final lecture.
So Dr. Ravindra Rao is not able to connect because of some medical emergency. So he's off for a case. I think with the final expert panel discussion, we can conclude this session.
Okay, so I think maybe Dr. Kastrati, would you like to sum up what we have today along with Rajneesh?
Yeah, I think before we sum up, Dr. Prabhakar Shetty was raising a finger. He wanted to add something for the last presentation.
Yeah. I have a question for Dr. Patrone. Have you used this IVL in carotid arteries, calcified carotid arteries?
Oh, that's a good question. I don't have experience. I'm sure that it has been used and there's some literature about it. And I think it's about how likely are you going to stent the vessel. I personally, this is like my own opinion, I perceive a Shockwave like an extremely useful tool, especially to avoid stenting. When you talk about carotid stenting, usually, it's very unlikely that you're not going to put a stent, because you want a permanent result with very good, long-term patency. And for the carotid, because the pressure is so high, I think it's more likely that the stent will go down. Having said that, I think that it's a very full. I didn't mention the little image, not about images, you can see how the calcium just cracks. So just open cracks in the calcium. You don't drill like other possible devices, like for example, atherectomy devices. So you don't create distal embolization. So in a territory like the carotid, where the distal embolization can be far more fatal than what can happen in the lower limbs, I think it could be a good tool. I'm not aware anyway of a huge experience in that segment.
Yeah. So I think pretty informative about the peripheral IVL use. Although we are not doing personally a lot of peripheral cases, but it may be a very handy tool, especially the lower popliteal region. Where we usually avoid stenting. We are looking for some tool where you can open up the arteries, make it patent, but no stent is required. So thank you, Dr. Lorenzo. And since we are coming to conclude this meeting, a few words from Dr. Ajit and Dr. Adnan, and then we conclude this.
Thank you, Dr. Kapoor. It was a pleasure to follow this session. I have only one comment for the last presentation. So what we are seeing now is to find a very special niche for the IVL balloon during the TAVI procedures, just to prepare the path for the TAVI system. So we are seeing more and more in this cases the need for the use of this. So just to sum up or to end this session, I always say to my young colleagues, you have to go to India to learn how to organize and to let run the symposia or the meeting. So this was also an example of your successful way doing that. And thank you very much for that. I would like to thank the presenter for their beautiful presentations. I would like to thank the panelists because of their lively discussions here in this session. My co-chair, Dr. Ajit Mulasari, it was nice to have him there. And before all, I would like to thank the moderator, Dr. Rajneesh Kapoor, for his excellent work. He had most to do during the session and he did perfectly. Thank you very much. And I thank also Translumina for organizing this wonderful session and collecting such big names for interventional cardiology and peripheral interventions. Thank you very much.
Thank you, Dr. Adnan. As always, it's wonderful to have you in these meetings. Dr. Ajit?
Yeah, well, I have nothing more to add. It's late in the evening, and I think, Rajneesh, that was a good job done moderating a very lively session. I think we really looked at calcium and heart lesions very nicely. We also looked at the balloons, how they have changed and how they've reduced restenosis and stent thrombosis. And we are looking at new evolving techniques to treat the unmet needs of calcium in other areas like peripheral and maybe like Adnan said in the aortic valve and like Prabhakar asked in the calcific carotid. So these are areas we need better tools. And I think this symposium will address some of those issues. Thank you very much for getting together this group and thank Translumina for this excellent meeting.
Yeah, same. I think yeah, Dr. Prajapati. You are muted. Please unmute.
Yeah, thanks. Thank you. Thank you so much.
Yeah. So do you wish to say something, Dr. Prajapati?
Yeah, I want to ask particularly that IVL peripheral cases. You after doing the IVL, you finish up with a drug-eluting balloon or just a plain balloon?
That's a good question. Essentially, there's I don't know if you're aware of the big debate that we have in peripheral use of paclitaxel devices. So essentially, we try to minimize the use of paclitaxel devices for, still no available data with certainty on the possible mortality signal raised by Katsanos in December 2018. So I use always, usually I use a plain balloon, but if it's something that I think that deserve a drug-eluting balloon, I use a drug-eluting balloon. The thing is, as Fanelli has described a few years ago, there's a famous paper, also the transmission of the drug to the vessel wall when there's a lot of calcium is very much reduced by the amount of calcium. It's not very clear if you crack the calcium, if the drug would receive this drug or not. Personally, especially in UK, we're quite conservative to sticking to the rules of safety, not using drug-eluting balloons. But I think it's a good choice anyway. Personally, I don't think there's a huge risk of death, especially for patients with CLI, where the mortality rate at 5 years is 50%. So I mean, we should really consider giving the best results. That's why I said, you can dilate with a shockwave, you can do plain balloon angioplasty, drug-eluting balloon, but also don't be shy in stenting if you really want to have, a good immediate result, let's say.
Thank you. Thank you. So with this, I think we conclude this, and it was really informative and we learned many things, many new tools and many new modalities and procedures were discussed in this meeting. So thank you. Thanks to all the presenters and speakers and everybody who was here till it's quite late now. And thanks Translumina, because Translumina is messaging me they're sending dinner to everybody who's still here.
Absolutely.
Even to Johnny.
Dinner is on us. Absolutely.
Thank you. So thank you very much. Thanks, Translumina.
Thank you so much. Thank you, everyone. Thank you so much.
Bye.
Rajesh, bye.
Okay.
Thank you very much. Bye bye.
Bye.
Bye, guys.